all net.
السلام عليكم. إن شاء الله إحنا خلال أقل من 5 دقائق نبلش المحاضرة ويا أستاذة سوزان. محاضرة اليوم موجود العنوان، هي مشكورة حاطتها قبل وقت المحاضرة حتى تطلعون عليها. بالنسبة لسؤالك دكتور عمر، تسأل على اللباس أثناء الامتحان. يفضل أن تلبسون اللاب كوت صدريتكم، وعادة تزودون بباجات بها الاسم والرقم الامتحاني حتى يعني تعرف نفسك للممتحنين، وتسلسل دخولكم وأسماءكم موجودة عند اللجان وكلها منظمة، وما يصير يعني اختلاط أو خلط بالاسم أو التباس أو هيك شيء. بس مع ذلك الباجات التعريفية شيء منها راح تكون معد من قبل المجلس وتسلمكم إياها أمينة السر قبل الامتحان. وأنتم يفضل أن تلبسون اللاب كوت لكم الصدرية البيضاء، وإذا باج تعريفي تحطه يكون أفضل، ولو أنا مثل ما قلت لكم أكو باجات تعريفية، بس الأفضل يكون احتياطا أنت جايب باج تعريفي باسمك. أثناء الامتحان العملي طبعا نفس الشيء، بس الكلينيكال يعني مثل ما خبركم أستاذ معاوية أنه أدوات الفحص الخاصة بكم الأفضل أنه أنتم تجيبوها، لأنه معتادين عليها وطريقة مسكها واستعمالها، عدساتكم الأوكسيلري لينزز على السليت لامب، التورش لايت، الأوكلودر، هذه المفروض كلها أنتم شايليها وياكم بالامتحان الكلينيكال. إن شاء الله جاوبنا على سؤالك دكتور عمر.
السلام عليكم أستاذ عليا، شلون الصحة؟
عليكم السلام أستاذة سوزان، أهلا وسهلا.
If we are ready we can start.
أوكي، إحنا بس 2 minutes ولو سمحتي حتى يكون فت بالموعد. إذا أمكن بس الطلبة الحاضرين نفس الملاحظة للبارحة، كثير منكم داخلين بأسماء مستعارة، أسماء الأجهزة أو أرقام تليفون أو شيء، رجاء التعريف بأسمائكم وغلق المايك أثناء محاضرة الأستاذ حتى لا يصير الديستراكشن. It's not mandatory for oral exam to wear the lab coat. It's okay for you يعني any official dressing، بس اللاب كوت بالكلينيكال exam مطلوبة. أستاذة سوزان، إذا شلون تحبذين أنت الاستجابة للأسئلة إذا طرقوها الطلبة أثناء المحاضرة؟ إحنا متفقين إنه يكتبون بالشات بوكس أسئلتهم، وعلى تفضيل المحاضر الإجابة تكون نهاية المحاضرة أو خلال بين الكيسات اللي تقدميها؟
أنا أفضل إنه بين الكيسات ناخذ الأسئلة حتى ما تختلط عندنا الأسئلة.
إن شاء الله. إذا اللي عنده سؤال يكتب على الشات بوكس، وبين الكيسات إحنا راح نجاوب على الأسئلة إن شاء الله عن طريق الأستاذة سوزان. إحنا we are in time we can start if you don't mind دكتورة سوزان.
أوكي. السلام عليكم. طبعا نشكر الأمانة العامة ونشكر أستاذة علياء لجهودها في تنظيم هذه الدورة واللي هي الدورة الثالثة، وأعتقد إن شاء الله يعني الكل يستفيد منها. اليوم احنا راح يكون pediatric session، ومثل ما تفضل الأستاذ معاوية يوم أمس إنه هو الموضوع مو lectures وما راح نتضمن مواضيع الثيوري مثل ما احنا نعرف كلتنا we pass the exam written exam و now we are going for oral exam. فممكن يكون احنا عندنا بعض المواضيع في بعض السنترز بها defect أو خلينا نقول not highlighted. راح نحاول اليوم to highlight some important points إن شاء الله احنا نكون بالوقت المحدد ونغطي المواضيع. So as a start we will say our objective إنه راح ناخذ كم important diseases and we will start to how to present and how to manage at the end of the lecture. كلنا نعرف انه البريماتشور نيو بورن بريماتشورز حاليا نتيجه التطور بالعلم، نتيجه التطور بالخدمه الصحيه more and more of these premature days alive، يعني بيجي حتى 26 اسبوع gestational age and they stay alive. So number of premature are increasing, and what is important for us, we all know that retinal vessels will reach normal growth at week 36 at the nasal part of the retina, reaching ora serrata. While on the temporal side, the normal vessel will reach about 40 weeks. So when we have a premature baby, the retinal vessels, they are not well developed, they are not reaching their destiny. So what will happen? Here is what will happen. What will happen, we will have a retinopathy of prematurity. Is it all premature kids should be screened? Otherwise, we will have a huge number that to be screened. Or there are certain parameter guidelines to be followed for screening. First of all, we say any premature before 36 weeks, we should examine their fundus. But priorities, we put priorities. What are these priorities? The priority is the risk factor. We have some of the risk factors are very high risk factors. So we start with gestational age. If we compare gestational age, 30 weeks and less, with those between 36 and 30 weeks, of course, those less than 30 weeks, they are at higher risk. So it is a high risk group. Then the birth weight, 1.5 kilo and less, they are higher risk factor for the development of retinopathy of prematurity. Number of the babies, single baby or twin or triplet. The more the number, the more the risk of developing retinopathy of prematurity. The general health, most of them, they may develop respiratory distress, they might have neonatal jaundice, which needs blood transfusion, they might have anemia, they may have fits with hypoglycemia or hypocalcemia, some of them might develop septicemia. So all these parameters we take into consideration to choose which baby to screen. We say we should screen them all, but not at the same time, and we need to put for them a schedule. Oxygen supplement. In past, they said that the oxygen was the cause. Now, we say it is not a cause, but if it is a high flow, uncontrolled, unstable, it may be additive risk factor. So always keep in mind, please don't tell a patient, a family, that they have a premature kid with ROP, especially when there is bad state of the retina, that the cause of the problem due to oxygen supplement, because it is not the cause, it is the cause, the other risk factor. We'll take, for example, this case, gestational age 35, birth weight 800 has a poor general health. You think parameters are good. We have two good parameters, but the bad one, it has poor general health. So we go for screening, and when we should screen them. We usually screen these neonates when? After 4 weeks of birth, or if they are reaching 31 week of gestational age, which is before. Yes, you know that from your guidelines. If you have case number 2, gestational age 33, it's very good. Birth weight 1750, again good. And he is healthy. 3 parameters are good. Shall we screen them? Here we think. Once the neonatologist asks you as ophthalmologist to examine the fundus, go and examine the fundus, but you can schedule this baby, you can schedule him as not an emergency. You can put him on the list for screening. If you are gestational age of 30 with birth with 2 kgs and he had a blood transfusion, surely you have to screen them as urgent as possible. When we go for screening for retinopathy of prematurity, first of all, we should put a schematic presentation for the retina. By the way, this is, you know, this present in your books. Why we need to draw the retina on the area zones? Because if we find any retinopathy of prematurity that need treatment, it will be according to the zones. So we start, for example, we examine the baby with indirect ophthalmoscope. You will use condensing lens plus 28. If you take this lens and the disc will be in the center of your visual field, in fact, this will be exactly the zone 1. The field that you see with condensing lens 28, it will be exactly zone 1. And you know how you will calculate the area of zone, which is the radius equal twice the distance between the center of the macula and the center of the disc. If you need to see the rest of the zones, when you move your lens and the disc will be at the margin of one side of the field, the end of the field will be about at the end of the anterior zone 2 nasally. Nasally, we don't have zone 3. We have only reaching ora serrata at zone 2. If we move the lens in such a way that the disc will be on one side, on the other side, it is the most temporal part of the macula. Here, we reach anterior zone 2. So even if you use the RedCam, it is a fundus camera, even if you use RedCam, using RedCam also, you can find these zones. Then they decided that there is the shaded area. You can see this shaded area. They saw that the most posterior part of the zone 2, which is adjacent to zone 1, حتى يعني هيك يعني تحس إنه هذه المنطقة لا هي بحق zone 2 to be safe ولا هي بحق zone 1 to say it is very critical. فخلوا لها تسمية posterior zone 2 واللي هي حوالي 2 disc diameters. وهي حقيقة كلش مهمة من راح نشوف الكيس اللي تحتاج treatment or no. الكريسنت اللي راح يبقى temporarily هو zone 3. طيب احنا عملنا الزونز وعدنا نقسم الرتنا الى كلوك اورز، وهذه هي تهمنا ليش؟ حتى بعدين من نرسم الريتينوباثي بريماتشور او نقسم. التشينجز اللي راح نشوفها فيها عندها ستيجز، اللي هي نبدي ستيج 0 اللي هي راح تكون we have immature avascular retina. ستيج 1 حيكون عندنا line white to gray line demarcation line اللي راح يحدد لنا منطقة الافاسكولار from vascular retina. After that there will be development of fibrovascular tissue. على هذا اللاين راح يصير 2 dimensions، راح يكون elevated وحنسميه ridge. still there is no new vessels, just fibrous tissue. When a new vessel will grow into this ridge and causing this ridge to become vascularized, and some of them even they go through that ridge into the vitreous, we call it stage 3. If we have a detachment, subtotal detachment, at the periphery, usually it is temporal, usually it is either anterior zone 2 or if it is in zone 3. If it is peripherally, we see there will be dragging of the retinal arcades, we see there will be macular dragging, and the detachment will be there peripherally, and we call it stage 4A. If the detachment at macula, we call it stage B, 4B. And the end stage or the end result of all uncomplicated retinopathy aperture untreated cases will be stage 5, in which we have either open funnel or we have closed funnel, and in 5C, it is the all complication. So why it is important for us to know the stages and to know the these stages we are talking about, why it's important, and the zones, because when we decide to write our report, it will depend on the stage and so on. Then there's an important thing to know, it is the plus condition. What is the plus? Whenever you have the tortuous dilated vessels, veins dilated, engorged, as in you see here in C, photo C, and there is the arteries also tortuous, we call it the plus disease. It should be present at zone 1. If you have tortuous dilated vessels at zone 1, so it is a plus. Some will ask if we have the same picture outside the zone 1, will we call it plus or not? They usually call it pre-plus, and in fact pre-plus it is a stage before plus. يعني كأنه هي مرحلة انتقالية من إلى البلاس، نكون قبلها بالبري بلاس. أي أنه إذا فحصنا الطفل for example فحصت اليوم وشفت عنده في 2 quadrants there is some dilated vessels, some tortuosity, but not involving the zone 1, so you will label it as the pre plus. Re-examine this child, this baby, after 72 hours. You might have see the full picture of plus disease. So that we will call it pre-plus and the plus disease. There is also a new terminology that they call it notch. Whatever the stage of rhopacate, it is stage 1 when we have the demarcation line, or stage 2, we have a ridge. This area will, let's say it is in zone 2 or anterior zone 2 for 5 or 6 clock hours. Then you will have an area of this ridge which protrude backwards into the zone behind it, which is posterior zone 2. And it might be for 1 or 2 clock hours. The importance of this node, they saw that presence of this node will cause that your labeling for the stage of the rope will differ. You usually choose the most serious zone and the most serious stage. We'll take an example for that. If you have, for example, stage 2 at zone 2 anteriorly, then you have a notch. You have a notch, and this notch reaching the posterior zone 2. So you will say that it is stage 2 zone 2 anteriorly with notch at posterior zone 2. It is more serious than having just stage 2 as anterior zone 2. Or we might have an area where it is still stage 1 border demarcation line. Then in 2 or 3 clock hours, you will find bit elevated ridge. So how you will label it? You will label it stage 2 or stage 1. You will label it as stage 2. So always in a staging, you label the most critical and the higher stage, because so that not to miss cases that will need a treatment. And we have another nomenclature, which is aggressive type of rope. You see, look at this photo. Very ugly, tortuous, dilated veins with multiple retinal hemorrhages. There is no ridge, no demarcation line. It is a stage 0, but you have a plus involving the whole fundus. It's aggressive, very aggressive, and they call it aggressive. If we look for this case, another case, you see, you have a ridge, it is vascularized, so it is a stage 3. If we try to see the zone, if you can see the zone, this zone, it is far away from it, it is reaching the anterior zone 2. It is anterior zone 2. You see the avascular retina anterior to it, but there is a plus. Plus with stage 3, even if it is in zone 2. So this is a critical case and need to be treated. How we will treat these kids? In fact, you know, the previous studies, there was a cryo study, then they saw that in cryo study, so many of the cases were missed. Then they will, that was, they depend on threshold stage to give treatment. Then they said, okay, they will start the early treatment. Other study, the early treatment study, they choose parameters which is not in the threshold level, and they call the pre-threshold level. And they started treatment using a laser photocoagulation. In laser photocoagulation, you will treat anterior to the ridge. You see here, this is stage 3. We have new vessels. We have a ridge, which is vascularized, and you have a tortuous dilated vessels. So what you will treat, you will apply 36 degree PRP anterior to the ridge, not to the ridge, not to the area where the new vessels. You will apply to the avascular retina. So when you apply to avascular retina in confluent laser spots to have a scar to destroy this avascular retina, which is the source of vision, which is the source of new vessel development. You save the vision, but photocoagulation, it's not an easy to be applied because you need a good anesthetologist. You will do it under anesthesia. You need a good dilated pupils, which is difficult in a newborn. In premature especially, their iris dilators are poorly developed. So, and you need a good expert ophthalmologist with indirect laser treatment. If we treat, for example, this case, the same case, look at here. It's a good laser scar. Look at the vessels. These vessels become less engorged. The ridge in some parts disappeared, but here it is present, is still present. During the follow-up, you will examine this baby after 1 week, and if you see there is still no regression, you need to do treatment again. And you might find the skipped areas, avascular edge, which is not treated, so you need to treat them to get a better result. As long as the cause of ROP is new vessels caused by VEGF, why not to give anti-VEGF? So from here came the BTROP study, where they decided to give the intravitreal anti-VEGF. They start to give it to with bevacizumab, now even ranibizumab and even aflibercept. These premature kids, they don't have only premature retinal vessels. These vessels could be premature even in the brain, premature vessels in the kidney. So the side effects on the whole body is still not well known. and therefore they decide to give the least dose, If we examine the baby with the anti-VEGF after 5 days, if anybody of you saw these babies before the anti-VEGF and after 5 days of it, it is a dramatic response. But the best response will be if we have zone 1. If we have the changes in zone 1. In zone 2, the response between not so much difference between laser photocoagulation and anti-VEGF, but the comorbidities that result from anesthesia and the difficulties to giving photocoagulation ترجح كفة الانتي-VEGF. Okay. How we know that there is regression? Okay. Of course, regression, it's obvious. We saw the photo before. The vessel dilated, the tortuous vessel will disappear. Okay, the new vessel will disappear. The ridge will start to be broken into parts. Segmentation, we call it segmentation. You see the ridge become in segments, and the normal retinal vessels start to grow through this segments and through this ridge, reaching the avascular retina. So this is a very good response regard in cases of anti-VEGF. The problem with anti-VEGF, there is good percentage of them with recurrence, so we might need to give again. And it might happen even months, believe me, months after giving anti-VEGF and after a good response. All of a sudden, during examination, we will find that there is an area looks like it is stage 2 or even stage 3. If you go back to the photos in your fundus camera, you see that 1 or 2 months before there was no such, so we will write that there is reactivated stage 2 or stage 3. How we will follow these neonates and for how long? And how we will plan to follow. For example, if you have a stage 0 in zone 2 and there is no plus disease, you think how many weeks we need to follow them? You need to have a plus, you need to have other 2 stages, and you need to change the zone to reach zone 2. So you can examine the baby after 4 weeks. But for example, if you have a baby with stage 3, with notch at posterior 2, and you have a pre-plus disease, what do you think? You need to examine him within 48 hours. Treatment of whether with photocoagulation or whether we are treating with anti-VEGF always will lead to some sequelae. These sequelae result from what? Even if the ROP will regress by itself, or we give a treatment, we have one of important sequelae, it is myopia. That's why we are saying these neonates should be nearly for life. Yes, you should follow them for life because they can develop myopia. They can develop myopia at any time, whether due to treatment or due to regressing a ROP, and myopia will lead to poor vision and lead to amblyopia. So you will save him from ROP, but he will end in myopia, and this will lead to amblyopia. So you might have crossed a child with sequent, and you examine the fundus, and you see during examination of the fundus strangely tortuous vessels, and you find that there is an area of lattice degeneration, or you can find an area which looks avascular, which what we call persistent avascular retina. If you go back and take it to history from the mother, she might tell you that he was premature and she forget to tell you. So we might have these findings in the fundus. We might come and encounter these findings when we examine a fundus due for a squint screening. Also, they are at risk to develop detachment. Usually, detachment will occur at the early junction between vascular and avascular region. We said before that if we have a dragging of the arcades temporally, the macula will be dragged temporally, and you have this photo. It says exotropia. In fact, it's a pseudo-exotropia, because when you do cover and cover, you find no corrective movement, no fixation, no corrective movement with this. Examine the fundus and you will see that how it is temporarily dropped, causing large angle kappa. So this is one of the sequelae for retinopathy of prematurity. Okay, if we have any questions regarding okay, one of the question, anterior and posterior zone 2. We'll go back. Zone 2. This is zone 2, which extends from the edge of zone 1, nasally it reaching ora serrata, okay? Temporally, it goes temporally, it goes about to distance from the center of the disc, distance from the center of the to ora serrata nasally, double it temporally. So the posterior zone 2, it is the part of the zone 2 which is adjacent to the zone 1, and it is about 2 disc diameter. It's about 2 disc diameters. Treatment in advanced stages where there's retinal detachment. The same, no. If we have a stage 4, stage 4A, in which we have localized detachment peripherally, the treatment usually will be buckling, or there will be some strap to decrease the tension on the tangential pull on the detachment. So they usually don't need vitrectomy, while in stage A, 4B, because there is macular involvement, they go for vitrectomy. Usually no much, it's not an easy surgery, and not all centers will do that surgery. Signs of improvement, I think we say that the signs of improvement will be regression of the tortuous and the dilated vessel. There will be regression of a new vessel, and there will be segmentation in the ridge, and the normal retinal vessel will pass through the ridge to the avascular retina to make it vascular. Screening at 31 weeks or 4 weeks post-delivery, which before or after. If we have a gestational age less than 30 weeks, let's say 26 weeks, and 26 weeks, 28 weeks, you'll go for 31 week or 4 weeks, which is before. Yes, we'll go like that, which is before. Buccal or P followed by PRP, correct. PRP, you cannot do PRP when you have a localized detachment. But in PPV, you will go for PRP. Of course, with PPV, you will do PRP. But with buckling, you don't go for PRP, because with buckling alone, there is no PPV. But if you do buckle and PPV, you will go PRP. We go for other subject. It is very common, and you all know it. It is retinoblastoma. Theoretically, we know the retinoblastoma, it is one of the common childhood cancer. You know, could be if it is bilateral. So usually in bilateral cases, it presents early, and in unilateral case, it presents a bit later. but believe me, we say it is around 12 months of age in bilateral cases, but we saw cases at 40 days of age with bilateral and stage D retinoblastoma, just as if retinoblastoma started intrauterine. In unilateral cases, around 18 months of age, but also you can see them as late as 6 and 8 years, which make the diagnosis dilemma. When retinoblastoma develop, it develops when we have both retinoblastoma genes mutated on chromosome 13. Okay, if we have familiar cases, it's usually germ mutation, but in sporadic cases, it is usually somatic mutation. So the common question and the common presentation in your practice will be leukocoria. We all, leukocoria is a common question and also in practice. So when we have leukocoria, always look to the red reflex. Look for this reflex. The white reflex in the pupil, look for the depth of that reflex. Is it very deep behind, coming behind from the retina, or it is more anteriorly? Here we have a photo. This boy has a cataract, so differential diagnosis cataract. You see this is pearl white cataract. It is more anterior. It differs from the one before. We saw it is more posterior. We might have other cause for leukocoria. Here there is a cataract and it looks like more posteriorly than the photo, and there is a shadow. Look at the shadow posteriorly. This line of shadow goes deep into the vitreous. This is a case of persistent fetal vasculature, and usually it is unilateral, and usually the eye will be microphthalmic. This is another case of persistent fetal vasculature, which is anterior. In fact, it is a little bit ugly. You see it is a cataract, membranous, and there is a vessel growing on the surface of the this lens. And there is these black spots at the periphery, just like fistula. These are ciliary processes. These are ciliary processes that has been pulled by contracting membranous cataract. And in fact, it can cause ciliary body detachment and can lead to even phthisis. You might have leukocoria due to extensive myelinated nerve fibers. And we might have leukocoria due to cicatricial type of retinopathy of prematurity, like this advanced stage. We say it is stage 5C. Look at the B scan, how it is a closed funnel posteriorly and anteriorly. Maybe at the macula we have toxocara scar, or even coloboma at the macula, or Coats disease. In advanced cases of Coats disease with late presentation, when there is exudative detachment, bullous exudative detachment with a large amount of subretinal exudate, it might look like really retinoblastoma with detachment, and you need to differentiate between them. In retinoblastoma, the blood vessel which run on the surface of the detached retina with the mass below it, you see that the vessel will be dilated and it will run on the surface, then it ends suddenly by dipping inside the tumor. While in Coats disease, the vessels, even if they dilated and run on the surface, if you follow them, they will not end inside the mass, but they will end with telangiectasic bulbs. So look for these two important things to differentiate between Coats, between retinoblastoma. And in fact, in life, sometimes still dilemma. We cannot differentiate. We need more and more to do. We might have this morning glory with chorioretinal coloboma, or we might have a coloboma or adjacent isolated area of coloboma adjacent to the disc. How to differentiate? Is it possible this is retinoblastoma or not? You see that area of RPE hyperplasia. You see the vessels running over it, and they are not congested. So it is not a retinoblastoma. Look at the, as we said, the reflex that comes in retinoblastoma. It is more posteriorly. In the first photo, you see the left eye, the left eye white reflex, and it looks deep. The other one, the right eye looks as there is pinkish to white, as there is blood added to that, or blood vessels on the surface of the tumor. So sometimes the reflex give us idea that this is a case of retinoblastoma or not. So once we have a case that we are thinking retinoblastoma leukocoria, first thing that comes into our mind, what we need to do, we go directly to the B scan. Please, always when we ask, it is in the exam, it is in our clinics, we ask the first thing after we see a child with leukocoria, first thing, do B scan. Because doing B scan will, in fact, help you to settle your mind what next to do. So if you do B scan and there is nothing posteriorly, and there is you will feel more happy and you feel more comfortable to do the rest of the exam. So we did a B scan, and you see there is a mass protruding from the retina, and there causing shadowing posteriorly, and also there is something whitish inside that mass. On A scan, you see there's spikes corresponding to this white material. So you think there is possibility this is a mass with calcification. Is it artifact or not? You go to decrease the gain. You decrease the gain to 40 or even 30. If still there is high spikes and still there is white area in the B scan, this indicates calcification. So our diagnosis goes with retinoblastoma. What is next? Of course, when the child will present with a leukocoria, while we're observing that child with leukocoria, we'll take the history. Of course, you will take the history while observing the child. So after the B scan, we go for examination under anesthesia. Do we need to examine a suspected case of retinoblastoma under anesthesia? Yes, you should examine under anesthesia, because you need to examine both eyes with a very well dilated pupil with scleral indentation, whether you use indirect ophthalmoscope or whether you use a RedCam fundus camera. You need to do it under general anesthesia or deep sedation, so that you will look for what? Why we need to examine under anesthesia or sedation? Of course, we examine the anterior chamber for presence of rubiosis or new vessels and for involvement of the anterior segment with the tumor, but also we need to see properly the posterior fundus. We need to see how many we have foci, how large their size, number, location, presence or absence of subretinal fluid, subretinal seeding and vitreous seeding, and how many areas of vitreous seeding. All these need to be documented by fundus photo, so that we will plan for treatment later on. After we finish our examination under anesthesia, what is next? We need to assess general condition. The general condition of this child, we can send them to a pediatric oncologist, so that he will do for him the rest of the assessment. He will look for any systemic involvement and metastasis, let's say chest x-ray, bone marrow aspiration, he will need a liver scan, he will need MRI for any CNS involvement, and full liver function, blood CBC. After all these will be done by the pediatric oncologist, and the imaging will go for what? How we will manage this retinoblastoma. The types of retinoblastoma, the international classification, you know, we have type A, B, C, and D and E. But as we said, when we do the examination under general anesthesia, after we put the type and we know that what type we have stage A or B or E or D. And the management of retinoblastoma, for God's sake, it is not only the act of ophthalmologist. In fact, we diagnose the case and we refer the child for further work, and there will be cooperation between us, between the oncologist. So always think as a team, and the treatment should be tailored to each case individually. We have guidelines, but each case individually tailored. How we will treat and why we treat and what our goals in treatment. We have a child with retinoblastoma. It is a cancer. The family will tell the family that your child had cancer. It is good if it is in one eye and it's type A or B, but it is what's if in both eyes? How we will tell them. If it is an advanced stage, how we will tell them. So always put the goal of treatment in front of the family. We'll tell them that we need to save the life of the child. This is the first thing, save the life. Then we try to preserve the growth and we try to preserve vision. Then, whatever the type of treatment we'll choose, we try to minimize the complications that result from the side effect of that treatment. Each treatment, whatever the treatment, it has some complication or side effects. So this is our goal in a treatment. How we will choose the treatment? We said it is teamwork. Yes, it is teamwork. But how we will choose our treatment depending on what? The type of the disease, as a staging, bilateral, unilateral, number of the lesion, the size of the lesion, if there is metastasis, the state, general the health of the baby. For example, if you have a chesty baby, ill, he cannot withstand general anesthesia, or he's severely anemic, poor health, poor development, that he cannot stand chemotherapy. So take in consideration the systemic status of the baby, visual prognosis. Is there any hope? Is there any hope to salvage this eye, which is a stage E? Usually say stage E, there is no hope for vision. So that's why once we see stage E, we don't think to salvage the eye and salvage vision. There is no vision, and there is no need to expose the child to an aggressive treatment with all psychological trauma to the child and to the family, trying to save a globe with no vision. So visual prognosis is an important factor in deciding what type of treatment. Then take in consideration possibility of other cancers. As we said, exposure in bilateral familial hereditary, there is a high risk of another type of cancer, which is in pineal. We call it pinealoblastoma. So how we will treat? In treatment, we have either focal treatment, which includes thermotherapy, thermochemotherapy, laser photocoagulation, or we can have radiotherapy, whether plaque or other external beam radiation. We have also chemotherapy, whether it is systemic, intra-arterial, or even subtenon or subconjunctival, intravitreal. And we have the surgical part, which is inoculation and exentration, and we have cryo. So all these options in the treatment of retinoblastoma. And we said we are a team. We'll act together to choose the best treatment for each case. So for example, if we decide that this case can be treated by focal treatment, so we'll choose photocoagulation. Photocoagulation, you know, in photocoagulation, whether you are using argon or diode laser, the aim is to reach the temperature of the retina will be above 60 centigrade. What? To cause coagulation. The aim is to cause coagulation around the tumor. We can see here, I will show this photo. Here we have a tumor localized mid-peripheral, surrounded by a laser, confluent laser applied around the tumor. Usually it should be away from the macula, away from the optic disc, away from papillomacular bundle. We can apply it, we cannot do it when it is on the vitreous base or very periphery, anterior to the equator, the very periphery. We cannot apply it, may be difficult. If it is, you can use it as a primary treatment in stage A, stage B, or you can use it as adjunctive treatment after giving chemo reduction, systemic chemotherapy. Then we have, and also we need to know the parameters that we are using, which should be less than 4.5 diameter in thickness, and 2.5 in thickness. Sometimes we need to use photocoagulation not to destroy the tumor, but to treat the new vessels that arise in the retina because of external beam radiation. External beam radiation overdose will lead to ischemic retina, and this ischemic retina lead to VEGF, and these lead to a new vessel formation. So sometimes we need to do photocoagulation to treat this avascular retina. 2 to 3 sessions can sometimes will be enough depending on the site. But to give photocoagulation, we need, in fact, to give general anesthesia. So we need general anesthesia. We need well-trained surgeon with indirect laser. Other way of treatment is thermotherapy or thermochemotherapy. In thermochemotherapy, we usually give chemotherapy for debulking, and after 2 to 3 cycles, thermotherapy will be given before each chemo cycle. Okay, in thermotherapy, we need to not to go beyond 60 the temperature, preferably between 42 and 45, because we don't need to do coagulation. What we need is that this thermal destruction for the membrane, for the protein denaturation, there will be chromosomal damage, and some form ischemia that causes necrosis of the tumor. The good thing in thermotherapy that, as we saw in this photo, we apply the diode laser, 810 nanometers, we apply it on the surface of the tumor. So we can use it on small tumors, and we can use, as we see here, we can use it with tumors that cannot be treated by photocoagulation, which is adjacent to the fovea or adjacent to the optic nerve. Okay, but disadvantages, it needs a good expert and surgeon. It takes time So if there is large tumor, we can, it takes very long time. It needs to be repeated. We need to photograph, document the tumor each time, and compare it before. In each session, we compare with the first one, so that to see how much has been treated and how much need to be treated more. So TTT and TCT is a good option in a treatment, whether as a primary or as we say, it's an adjuvant to chemo. In cryotherapy is in fact is one of the oldest way of treatment other than inoculation. When we have a tumor at the vitreous space, we have a tumor anterior to the equator. When we have a tumor should be less than 2 millimeter in thickness and less than 3.5 diameter. So in such cases, we can go for cryo. But if there is vitreous seeding, cryo cannot be done. In cryotherapy, the freezing will cause destruction, formation of crystals inside the tumor cell and cause these cells to rupture, and there will be vascular occlusion, necrosis, and the tumor will be destroyed. But it is complicated also. It needs general anesthesia. Needs expert one with using indirect and the cryo. Might have over freezing might lead to vitreous hemorrhage, vitreous choroidal effusion, sometimes even retinal detachment. In stage E, we all know we need to do inoculation, and if for any reason in a very late presentation, when there will be orbital involvement, that not with extension orbital tissue involvement, we sometimes, if they don't respond to external beam radiation and systemic chemotherapy, sometimes we might need for excenteration, which is unlucky. Some will say that I did a treatment and how I know that this tumor had responded to treatment. This is a case, we see they have two tumors, they are large enough, we can say it is a stage B, which is adjacent to the optic nerve, one of them in the macula. So first of all, we cannot treat this tumor with photocoagulation. So we put a cross on photocoagulation. What else? Can we treat it with TTT? I don't think with TTT you can be treated because it is large and thick. Large in diameter and thick. What else? What else we can do? Brachytherapy, you cannot do brachytherapy. It is on the posterior pole. What else? External beam radiation? No, it's a high risk and we don't need to take the risk unless we are obliged to for that. What else we can give? We can give intra-arterial chemotherapy. In fact, the intra-arterial treatment in this case was done, and you see the second photo, the two lesions totally disappeared. And there is a scar, flat scar, instead of these two tumors. So this is one of type of response when you have scar, atrophic scar. Other type of response, when you have a huge endophytic tumor with detachment, and when it will respond to treatment, which usually chemotherapy or brachytherapy, the response will be the tumor cell would die, and what is remaining is a calcified mass. So other response, what we call calcified mass, or we call cottage cheese. This is the lower photo. You see there is a large mass which is calcified cottage cheese and surrounded by a scar. So there is a combination of two type of regression. Some will, for example, if one will come across this slide and in the exam or in your life, and you will say to me, this is a retinoblastoma. To say this is active or not active retinoblastoma, please look at the blood vessel. You see that the blood vessel which is running the main blood vessel running over the mass. You see it's running over the mass. It is not engorged, it is not tortuous, which means it is not a feeder, it doesn't nourish the tumor. That's why it is of normal size. And as we said before, it doesn't dip into the mass. So this is a regressed, well responded to treatment, cottage cheese appearance. And the third type of presentation, what we call it the gray, it is a translucent gray appearance, and they call it fish flesh appearance. Little bit difficult to be differentiated, in fact, from a newly early developing lesion, because that one also appear as grayish, little bit translucent. So that type of response to treatment question need to be well and more close followed, because possibility we can mistake it as a response rather than a new lesion. But most of the cases, the combination of three can be present in the same regressed tumor. I think this is the retinoblastoma. We finish it. We'll look for your questions. How to give the anti-VEGF? This question for the ROP, you give the minimal dose, and it is the half the dose of the adults divided on both eyes. Intraarterial, into which artery? Of course, what do you think in which artery? We are giving it to the ophthalmic artery, and it is given by catheterization. They use a balloon to close the possibility of seepage of this chemotherapy in any other artery other than ophthalmic artery, okay, so that it will go directly into the central retinal artery. And also one of the complications sometimes, if it is given by non-expert, there is high risk of complication, because it will go into other possibility to go to the other eye also. If there is no more question on retinoblastoma, we'll go for other subject, which is childhood glaucoma. We all know the triad, if you have, we all learn that and present in textbook. Triad of epiphora, photophobia, corneal haze or a large cornea or ophthalmics. It means congenital glaucoma. Okay, so it's a good thinking to think that this congenital glaucoma, but we should keep in mind conditions that can come across with such same presentation. So if we take the epiphora, congenital glaucoma is one, but we can have a conjunctivitis. Yes, we can have conjunctivitis. So you should rule out conjunctivitis by examining the fornices for a congestion, for any purulent or discharge, for a sticky lids. Because in epiphora, due to glaucoma, there won't be congestion. There will not, unless late stages, or there will not be not sticky lids, no crusted lashes. Then we have possibility of congenital nasolacrimal duct obstruction. Again, how to differentiate it? Just press on the lacrimal sac and look for a reflux of muco or purulent or mucopurulent discharge. Possible there is, we have a corneal problem like keratitis or epithelial defect aberration or foreign body. So we can examine the cornea, put a fluorescein stain and see if there is any ulcer or aberration or sometimes foreign body. Other conditions that can be mistaken for congenital glaucoma, or the congenital glaucoma will be misdiagnosed because of we didn't think of it, is when we have cornea, large cornea, or which is hazy, grayish in color, as we can see it in congenital hereditary endothelial dystrophy CHED or in posterior polymorphous dystrophy, although these will present little bit later. In the first year might appear and later, not at birth. At birth, usually later need to be present. Or we can have a trauma. If we have a scar, we think this is Habs-triad. Possibly this is due to obstetric trauma. Or we can have a storage disease as mucopolysaccharidosis, cystinosis, or sphingolipidosis, okay? Or we may have just sclerocornea or Peters anomaly. Again, keratitis, especially rubella, may cause such presentation. If you have a large globe like this child, large globe, you think congenital glaucoma, but we might have axial myopia. Axial myopia, which may present as a large globe mistaken for congenital glaucoma or amygdalocornea. In fact, you will see in your practice some kids present to you at, let's say, at age of 4 or 5 years, and they will give you a history of surgery for glaucoma, and when you examine them, you find, yes, there is a trap, we have a peripheral iridotomy, and when you will, and they have a poor vision, you will believe that they have a poor vision because of that. Then if you do refraction for them and you examine the axial length, you find that they had axial myopia, pathological myopia, and their large globes are mistaken, improperly assessed during child early days, and they were exposed to a surgery which was unnecessary. So be careful not to mistake them for congenital glaucoma, and at the same time, I don't want you to misdiagnose congenital glaucoma. Sometimes when we examine a fundus, for any screening of the or due to school screening with poor vision, and you examine the fundus, you might have coloboma of the disc, or you might have large tilted disc, or you might have optic atrophy, or in one eye we have hypoplasia. All these can be mistaken for disc due to congenital glaucoma. Look at this logarithm. It's present in your book in AAO. You can go and read it. The important things that I highlighted in this logarithm is these two following slides. The first of all, when we say we have a primary congenital glaucoma with ophthalmos. When ophthalmos, it means enlargement of the globe. So when it happens, if we have a ophthalmic eye at first month of life, then we call it a neonatal primary congenital glaucoma. If we have a ophthalmos during the from first month to first 2 years, and during first 2 years passing developed anytime during this period, we call it infantile primary congenital glaucoma. Anything after 2 years, we call it late onset congenital glaucoma. In fact, the presentation, when the family will present the baby, but by history, we should depend on the history, or we might use photos to know exactly when the ophthalmos appear, because they might suddenly decide to bring the child for you for examination. But it was neonatal. It is not infantile, because it appeared at the age of 6 or 8 months. It already was present at birth. So sometimes if you cannot find or get a good history from the parents, go for the photos to examine this, if there was a ophthalmos at first month of age or not. The same logarithm has many important things, and this group, the Glaucoma Research Network Association, They took 9 diagnostic features for childhood glaucoma and for glaucoma suspect. First of all, we'll talk about the intraocular pressure. We know intraocular pressure, it's 21, it is abnormal. But remember that most of your new kids, let's say neonates, infants, you will examine them under sedation or under anesthesia. If you examine them under anesthesia, so what type of anesthesia? You should know that. For example, if you are using halothane, if you are using halothane, the IOP will drop to 10. So if you are examining under halothane and the IOP 20, so it means a high intraocular pressure. So usually we avoid halothane. We try to do sedation. If it is the first month of presentation, we can start, we give him bottle feeding, good topical anesthesia, and try to examine intraocular pressure while he is sleeping or he is feeding. Or we might give some sedation like chloral hydrate, dose 25 to 50 per kg. We'll try to give chloral hydrate. The child will be sedated, well topically anesthetized, and try to measure the intraocular pressure. Some will say it was Perkins. I will say to you, even with Tonopen, the easier and the more rapid the Tonopen than Perkins, because in Perkins you need to apply fluorescein, you need to see the Myers. While in Tonopen it is much easier, especially if the child is not anesthetized, if the child is just sedated or bottle feeding. Then you need to examine, of course, the CD ratio, if there is any asymmetry, so it is significant, and there is focal thinning of the optic nerve. Look for the cornea. Is there corneal edema? Is there Hubs stria and the diameter? Then we have some, as we said, sorry, what's going on? Okay. If we have a diameter of the cornea 11 millimeter in a newborn, so it is significant. If we have the diameter 13 at any age, it is significant. Axial length, always measure the axial length. To say or to label a childhood glaucoma, we need to label the childhood glaucoma if we have 2 of these diagnostic features, so it is a childhood glaucoma. If we have only 1, let's say, take for example, you have a corneal diameter of 11 at age of 1 month, and that's it. You don't have anything else. IOP normal, fundus normal, there is no normal axial length, nothing, just corneal diameter of 11. Will you label him as a glaucoma or no? No, we'll label him as a suspect. Re-examine again after, let's say, after 1 month. Retake the measurements again. If we had the measurements while he was sedated, not anesthetized, and it was not very cooperative, so repeat it under anesthesia to be sure. So sometimes we need to re-examine the baby many times before we will say it is not a suspect or it is a glaucoma case. Always when you take the child to the examination room, whether under general anesthesia, under sedation, do these things. First of all, examine the anterior segment, do gonioscopy, look for the angle, and you did the corneal diameter, you look for the fundus, you do the cycloplegic refraction and take the axial length, and if you have a fundus camera, photograph and document the optic nerve, so that when you come again and repeat these same parameters, you will see the changes to decide is there any propagation, or you change the diagnosis from suspect to a childhood glaucoma. So how you will treat glaucoma? Childhood glaucoma equals to surgery. Yes, surgery. Surgery, it depends. If it is a clear cornea, you go for coniotomy. But if it is opaque cornea, you go for ab-externo trabeculotomy with or without trabeculectomy. If you do trabeculectomy, we usually do it with antimetabolites to decrease the risk of failure. With medical treatment, when and where we use medical treatment. Medical treatment while we are waiting for the operation. Some will say it is emergency. Yes, it's emergency. But if his general health, if he is unwell, if the age of the baby 40 days, he has bilateral, for example, bilateral, opaque, totally opaque cornea, stony, hard, so intraocular pressure very high, but he's the baby unfit, the general anesthesia is very high risk. Neither the anesthetist, neither the family agree for this risk, so you need to wait until he is stable for general anesthesia. So what you will do, you will go for medical therapy while waiting for stabilization of the condition to be able to do the surgery. What you will give? Usually we try to avoid beta blockers, or if we need to give, we'll give beta blockers in a percentage 0.25, and we teach the mother how to close the press on the canaliculi and occlude the nasolacrimal passage for 5 minutes so that to decrease systemic absorption. Of course, brimonidine contraindicated in first 2 years, so we go for dorzolamide better. Good surgery, good control of intraocular pressure, and we preserve vision. This is our aim. But if the congenital glaucoma was present at birth, as the scenario I just said, we have bilateral opaque cornea present at birth, whatever you do, whatever the surgery do, okay, there will be clearance of the cornea, there will be improvement, but still half of them will end blind. If we have a horizontal diameter of 14 millimeters, it's a bad sign, bad prognostic sign again. The late presentation, as in during the first year, from 3 to 12 months of age, it gives a better prognosis regarding the response to surgery and regarding visual rehabilitation. If we have a good surgery, you have a good surgery. You did a very good surgery, and you have a very good control of intraocular pressure, and you are following meticulously, you are following your patient with a regular follow-up, and your patient is, and you examine visual acuity each time, and it has a poor vision. Why your patient has a poor vision? First of all, possibly because the corneal problem, which is a scar, herpes striae causing stigmatism, opacification because of late presentation or because of bad surgery, or because it started intrauterine, so it is opaque, severely edematous. Whatever you do, you will control, but still there is hazy cornea. This is one of the causes of poor vision. The optic nerve damage, yes, it is one of other causes. And the most common cause for a well done surgery and well-controlled intraocular pressure, the main cause is amblyopia. And this results from the axial myopia. That's why we say every time you take a child with congenital glaucoma to examination room, whether under sedation, whether anesthesia, axial measurement, axial diameter, and refraction should be done, because so that not to miss the myopia and not to miss the amblyopia, and good treatment of amblyopia will improve the vision and you will might have even strabismus if you have high myopia which was not treated properly. You might add with the strabismus, and by itself strabismus will cause amblyopia. So you have dual causes for amblyopia and a vicious circle. So always screen them for amblyopia and find the cause of amblyopia and treat amblyopia. We'll go for your questions. Scenario where a child has only bilateral corneal diameter of 11 and long axial length. Is it considered glaucoma? Glaucoma suspect on long axial length. We said diameter of 11 at what age? If it is, go to the guidelines. If it is at age of 1 year, so it is normal to have 11. But if it is 11 at age, while he's newborn 11 and more, newborn 11 and more, it is abnormal. So if we have 11 and he is newborn, we consider it abnormal. And we have a long axial length, which is not compatible with the age match, so it is a glaucoma case. 1 month, above 1 month, 11 is normal. Below 30 days, the first 30 days, 11 is on the edge. Okay, I think this question has been answered, or if you need another question, I'm ready. Thank you very much for your attention. Good luck with the exams. And if you need any question, I'm ready. Even if about another subjects also, we are ready.
شكرا جزيلا أستاذة سوزان، المحاضرة جدا قيمة والمواضيع مفيدة وأكيد من المتكررة بالامتحانات. بخبراتكم أنتم بالسنين الفايتة هاي الكيسات كثير تتكرر على الطلبة.
شكرا لحضرتك أستاذة أليا على الإتاحة الفرصة إنه نشارك، وإن شاء الله يكونوا الطلاب استفادوا. What about strabismus? What are important points? يعني هو الاسترابيزمس all important points، كل انواع الاسترابيزمس تيجي بالامتحان اكو عندنا اشياء ثابته، هذه الثوابت لا تنسوها. الثوابت اللي ما ننساها ونخليها امام الممتحن هي always say check visual acuity, do cycloplegic refraction, examine the fundus, treat amblyopia, do ocular motility and cover test. انت هيك سيطرت على الممتحن. انت من تنطيني انه انت عملت you check the visual acuity, you did cycloplegic refraction. Don't forget the word of cycloplegic refraction, please. So you check visual acuity, you check cycloplegic refraction, you check the fundus to be sure there is no lesion, because we said retinoblastoma can present due to what? As in case of strabismus, or we can have a pseudoexotropia due to large angle capilla, which is drugged by retinopathy of prematurity. So fundus examination, if you do all that, you are now safe in the safe zone. Then you go for cover and cover, or you will go for motility to decide what type of strabismus you have been presented. أعتقد ماكو بعد أسئلة. Do we need to know staging of retinoblastoma? طبعا. You should know the types according to international classification، لأنه بالامتحان حيجي إذا إجا سلايد كيس الريتينوبلاستوما لازم أنت تعرف أي ستيج هذه الريتينوبلاستوما، لأنه من عندها راح ندخل على أي نوع تريتمنت ممكن. Guidelines for implantation of intraocular for IOLs. الجايدلاينز اللي احنا نعرفها كلتنا انه we don't implant IOLs before age of 1 year unless unless خلينا نقول unless it is a unilateral case. فممكن sometimes below 1 year in some centers، يعني تخلي للممتحن الجواب انه في بعض المراكز المتقدمه باليونيلاترال كيسز ممكن اذا عندهم الامكانيه لقياس البايومتري بطريقه صحيحه واللي حصول على intraocular lenses which is customized to this child. في هذه المراكز ممكن نزرعها قبل السنة، بس عادة باليونيلاترال بعد السنة وبالبايلاترال بعد السنتين. تفاصيل السيرجري، طبعا تفاصيل السيرجري احنا هنا راح اي سيرجري، يعني أنا السيرجريز اللي نعملها الحياة اليومية اللي أنت تعملها you should know، يعني أنت لازم تعرف كيف تعمل الcongenital cataract surgery، كيف تعمل الاسترابيزمس، كيف تعمل الاناكوليشن، كيف تعمل البروبينج بالنيزولاكريمال دارك obstruction. هذين التفاصيل المطلوبة منك، بس ما راح أطلب، أعتقد ما راح نطلب من عندك بالبيدياتريك كيف تعمل البي بي في for retinopathy of prematurity بالستيج 5C، أكيد ما راح نطلب هيك. ايم الظاهر بالcongenital cataract الايم hypermetropia ametropia or myopia عندنا يعني اللي يفرق if it is bilateral or it is unilateral راح يفرق. If it is bilateral so راح يكون عندنا different theories، وهنا الفاميلي كونسلنج. ليش عندنا فاميلي كونسلنج؟ لأن أنت للفاميلي راح تاخذ موافقتهم إنه هذا الطفل عمره 3 سنوات حزرع له intraocular lenses، لكن أني أفكر راح يكون عندي مايوبيك شيفت لما بيكبر، وهذا المايوبيك شيفت ما مضمون يعني لأي درجة يوصل. sometimes it can reach as -12. فحتى ما يصير عندنا مايوبيك شيفت عالي ونقلل الاحتماليات الحاجة إلى العملية الثانية اللي هي عملية أما إحنا we will exchange the IOL or we will do add correct the refractive error، ممكن إنه فيما بعد حتى بالrefractive surgery. فإحنا we consult the family، يا أما إحنا هذا الطفل now عمره 3 سنوات راح أسوي له البايومتري وأحسب حساباتي إنه أخليه هايبرمتروب حسب إنه جدول rule of 7 أو عندنا rule of يعني الأيج، وفي جدول ممكن أنت تطلع عليه وممكن تحفظوه. هذا ممكن أنت تخليه هايبرمتروب في البداية، وأنت as he is growing إيش راح يصير عندنا؟ راح يصير عندنا gradual myopic shift، وبالتدريج راح تقل درجة الجلاسز فور اللي حيلبسها الهايبرمتروبيك جلاسز إلى أن يوصل ممكن الage of emmetrope راح يكون emmetrope، أو at least راح يكون mild myopia، mild degree يعني small degree of myopia. إذا الفاميلي قالوا لا إحنا عمري بهالعمر والطفل يتحرك وممكن يكون يعمل له بولينج وممكن يوغا وممكن تتكسر النظارة وإحنا نخاف من إنه يلبس النظارة بهالعمر، إحنا نفضل إنه هسه يكون هو إمتروب، هو نظره يكون جيد بالوقت الحاضر، والله كريم إذا حدثت صار عنده مايوبيك شيفت أو لا في وقتها الله يحلها ونلبس glasses. So you will go for emmetropia and then you correct accordingly the myopia shift that will develop with time. يا حبذا إنه في أي شيء يا عمر الimportant studies، على أي studies أنت تتكلم، إحنا ما تهمني أنا الستديز إذا قصدك بالروب. الستديز اللي يعني تسأل عليها الامبورتنت ستديز انت هي اللي تهمنا هو الحقيقة الأخيرة اللي هي البيت ستدي، واللي قبلها كان الإيرلي ثيرابي ستدي، الفوتوكوagulation ستدي، لأنه هذين التو ستديز اللي غيرت المجرى من الاعتماد على الثريشولد بحدة and missing so many cases إلى treating more cases and not to miss any case that need treatment. So both of them, واحدة للphotocoagulation والbeat study للanti-VEGF. So these are the two important studies. وفعليا ما راح يكون في وقت لسؤال على الstudies. هذا we covered during the امتحان الكتابي اللي حتسألون عنه، حتسألون الكلينيكال بوينتس، الكلينيكال relevant to clinical case. فحقيقة ركز على الاتجاه الكلينيكال، على الاتجاه اللي يخص موضوع how to reach the diagnosis and how to answer properly. إذا ما في أسئلة إضافية ممكن ننهي السيشن. أستاذة عليا، ولا تعتقدين في أسئلة إضافية؟
أعتقد يعني we are running out of time، وإذا ماكو أسئلة هذا سؤال إجانا بالوقت الضائع. الرش ديزيز،
الرش ديزيز بالروب هو نفس اللي احنا نعتبره اللي هو الاجريسيف تايب اوف روب اللي كان السلايد مالته معروض مالته، اللي انه راح يكون عندنا all posterior fundus with tortuous vessels. Let's say this one. This is the rush disease. You see all vessels engorged, tortuous veins and arteries. We might have retinal hemorrhages, so many retinal hemorrhages, and involving the whole posterior retina. In fact, if you examine the next day, you see it is even more aggressive. So this should be treated immediately. Immediately should be given anti-VEGF.
شكرا جزيلا دكتورة سوزان لدعمكم للدورة التدريبية المرة الثانية، وإن شاء الله الفائدة عامة للجميع.
إن شاء الله. شكرا جزيلا و good luck للجميع.
إن شاء الله.
مع السلامة.
الله معكم.